go ahead and talk about corporal punishment. The reason that this is, several different reasons that this was on my mind as a topic for today. And one of them is that the American Academy of Pediatrics has recently come out with a new statement about it. And I'm actually one of the chief authors of the last statement. So I was particularly interested to see what they did and what has changed about it. And it's still a very relevant topic. So just to remind you, we're the creators of Chattis, so we have a conflict of interest. So in 1989, which seems like a really long time ago, the UN had a convention on the rights of the child. The committee was called the Committee on the Rights of the Child, and they actually came out with a statement that they all agreed on, which was to ban corporal punishment and to teach positive discipline. So I'm not proud of the United States as not signing on to these things. I'm not proud of them with regard to the climate accord, and I'm not proud of them for not signing on to this. But I thought it was interesting, with all the problems there are in the world, that the UN decided that this was an important enough topic to come out with recommendations. And I think it's helpful to see what they used as a definition of corporal punishment. And that is any punishment in which physical force issued and intended to cause some degree of pain or discomfort, however light. So this clearly includes spanking. So the examples they gave, this is from the statement, included smacking, slapping, or spanking with the hand or an implement. Obviously, when you start using implements in the United States, that constitutes child abuse if it leaves bruises. Kicking, shaking, or throwing, scratching, pinching, biting, pulling hair, or boxing ears. Well, it's sounding very archaic here. Forcing children to stay in uncomfortable positions, which is really interesting. I ran into a family not too long ago who had the child stand on a tin can in the corner. And that was clearly a very uncomfortable thing for that child to do. Burning, scalding, or forced ingestion, that includes washing the mouth out with soap or forcing them to swallow hot spices. I even know a pediatrician who recommends this. And then in addition to that, they also banned, or proposed that you should ban belittling, humiliating, denigrating, scapegoating, threatening, scaring, and ridiculing the child. So that's a really broad statement. And the Academy is not nearly as brave as the United Nations Convention. And this is their new policy that just came out in December. So have you seen this already? Diane, have you seen it?
Yes, I have.
It's good. So we're going to be talking about that some today, but talking about it short forms, I think, too. So basically, what's different between this policy and the last one is the last one wasn't actually a policy. It was guidelines for discipline, because at that time, the Academy wasn't feeling bold enough to say there was a policy. The problem with a policy is that there's potential for people to be held to not doing proper care if they don't follow policies, whereas guidelines are looser than that. So this new one, and I put the italics in, said that adults interacting with children and adolescents should not use corporal punishment, including hitting and spanking, specifically, either in anger or as a punishment for or consequence of misbehavior, nor should they use any disciplinary strategy, including verbal abuse, that causes shame or humiliation. So this one actually follows the UN standards much better than the last one did. But then when they start saying what pediatricians should do, you notice that they soften it up a little bit. They may choose to offer the following. They may: guidance on effective strategies, information about the harmful effects and ineffectiveness of corporal punishment, and the insight that although many children who are spanked become happy, healthy adults, current evidence suggests that spanking is not necessary and may result in long-term harm. That's to help counter the argument that I was spanked and I came out okay, which is something that a lot of adults say, including pediatricians. And then the Academy always likes to encourage other agencies that follow Academy policies that they should offer family support and encourage the provision of information about effective alternatives to corporal punishment, including links to materials, such as the ones from the AAP, and that we, in our role as advocates, should be encouraged to help advance this policy. So that's the new policy. So mostly it's pretty much the same, except that it's now saying that they should not use. It's not that they should encourage not using, it's that they should not use. And it also includes verbal abuse. So what has happened over the last 2 decades, basically, is that pediatricians endorsing spanking as a positive a disciplinary strategy has dropped dramatically, so that now, as of 2016, only 6% of pediatricians endorse spanking as positive. It's not the same to say that they say that you should never spank, by the way, if you look a little closer into the recommendations. And the other thing that's interesting is that this generation of parents, those who are under 36 years old as of 2013, have a lower endorsement of spanking, a lower intention. Now, what was not in this is how old is the kid of these parents, because the reality of being a parent is very different than your idea when you have your 2-week-old in the house who you can hardly even imagine walking across the living room without being really, really careful. What happens by the time they're 2 and acting up can be very different. So we don't know exactly how old the kids were that these parents had, but only 72% endorsed spanking. Now that's not like the minority still, but in 1995, the overall rate for parents of all ages was 87%. So it looks like maybe we're going in the right direction. And it turns out that parents mostly look at other parents at the social scene to decide what kind of parenting practices they should do. They look to pediatricians second. So they look to social first, and these days that probably includes, Twitter and Facebook and stuff like that. So I just want to remind you that these are the approximate rates of corporal punishment by the age of the child. And to me, this is a stunning slide. Now, this is not an updated one because we don't have updated information about how much corporal punishment is occurring at different ages, updated to now. But take a look at this. 25% of kids 1 to 6 months old are getting hit. And then it goes up with a peak at around age 3, which, by the way, is the age at which aggressive behavior really starts to decline. And externalizing behaviors are the main things that kids get hit for. But you still have significant rates, 40% of 14-year-olds and 25% of 17-year-olds. Now, if you hit a 17-year-old, what do?
They hit you back.
What do? They hit back, right? Or they run away, right? So it's a very different kettle of fish when you get a 17-year-old, but still 25% of them are being hit. So I think that this is really...
There's a loud buzzing noise on the phone.
I'm sorry. If you're not talking, please mute your phone, and then when you want to talk, just unmute. Okay, I don't think that's coming from our end. Let's see. Very good. Thank you. That helped a lot. I don't know who that was. Somebody had a printer in their background. Great. So that's really important. Now, the other thing that's important about this slide, in my opinion, is that while typically when I'm doing general pediatrics, I'm talking about discipline definitely at the 12-month visit. On some level, it's late. It's a late time to talk about it. We really need to be talking about it earlier than that when you look at these numbers. That's something to keep in mind in general pediatrics. So an overview of the problems of hitting children include the fact that people do it impulsively. And because they do it impulsively, they're not being planful, and it's often poorly modulated, meaning it can be a lot harder than, they may hit a lot harder than they really intended to do, or a lot longer. They also tend to do it inconsistently. And in general, people don't like hitting their kids, so that when they do it, they're not actually doing it in a planful way. All of these hitting and swearing at kids and putting them down are disrespectful things from the child's point of view, and are known to lower self-esteem, and they increase aggression, and interestingly enough, they increase sibling rivalry as well. Even if the sibling is not getting hit, the kids, maybe it's because these behaviors they flow downstream. So the siblings get it. If the kid gets it, the sibling gets it from the kid. They're not educational in themselves and tend to replace other forms of management that would be more instructive for the kid. They don't work well at older ages, long term, and they tend to produce fear and anger and inhibit other behaviors, such as maybe negotiating, the kid being able to negotiate or explain themselves for why they did a certain thing. And we know it's associated with lots of long-term side effects, which I'm going to go into a little bit more in a minute. So this stuff is not so easy to change, however. And I think that's part of why I wanted to talk about this, because it's one thing to say, okay, here's the policy. You can print it on a piece of paper and put it in your waiting room. But actually, it just isn't that easy to change people's practice. And one of the reasons it's not so easy to get people to stop spanking and hitting is because it looks like it works. But the pause in behavior actually does stop behaviors pretty much instantly, which is very gratifying to the parent. But when this has been measured, the kid goes back to the same behavior within 10 minutes. So when you really talk to parents about how did it work, they will usually say, yeah, it worked great. And then if you take a pause and you say, and how long did the kid continue to behave well, they'll recognize that it was only for a few minutes. And that's an important kind of insight to have, because these instant results are really very reinforcing to the adult. Shut up, smack, okay? And they stop, they do shut up, right? It's also kind of a welcome release for the parent who may be very tense and upset about the child's behavior. And when they do the hitting, they actually feel better, which is too bad because it reinforces them. We've got to remember that most parents who hit kids were also hit growing up. In fact, in a poll, there's a Harris poll in 2013 about hitting practices, and 95% of the parents who spanked their kids had been spanked when they were growing up. 95%. And only 5% of those who were not spanked were spanking. So, interesting. So, why is that? Well, because you tend to do what your parents did to you, right? It seems natural. It feels like an appropriate method of parenting because, after all, their parent loved them and had reasons for disciplining them in this way. And it also gets in your brain when you're really young, before you're thinking about it in a logical way. Because hitting, as it turns out, is really not a very logical decision at the moment, but more like a reflex that's reinforced by your early experiences as well as your current circumstances. So the immediate effect is to stop the behavior. But then there's some other immediate effects, such as the kid screaming, saying to the parent, I hate you, throwing things at the parent, stomping up to their room, running out of the house. And while these may be upsetting because the parent doesn't want their kid to be upset, it actually may look like they've been effective if what their unconscious goal is to cause the child to take them seriously and to be upset. Children definitely are upset when they're hit. In fact, some of the worst hitting I've seen is when the child grits their teeth and smiles at the parent with one of those smiles. Parents get really mad if it doesn't look like the kid got affected by their discipline, right? Then sometimes they come at them even harder. So the child who cries is actually they're likely to stop hitting at that point. Now, so those effects may actually reinforce the parent for doing it. It's the later effects, hours or days later, that parents don't necessarily connect to the spanking that's part of the problem. So kids feel degraded by this kind of discipline. And then they get back at the parent. They talk back, they act sassy, they refuse to follow directions or cooperate. They start acting mean to their siblings, or they kick the pet, or they fight with peers. And those are just the kinds of actions that the parent hit them for in the first place. So now we have the hit, act up, hit cycle, which perpetuates corporal punishment if the parent just doesn't get the connection between the fact that the way they're disciplining the child, if they call it that, the way they're punishing the child, is actually creating these other negative behaviors. I'm dealing with a teenager right now whose parent doesn't see that the way the parent screams at the kid is resulting in the kid screaming at the parent, which the parent then says, you're being disrespectful, and they punish the kid for that. So it's this kind of cycle, is amazingly invisible to some parents. And I think that one of the ways I talk about this with parents, and I'd love to hear what you guys have to say about that, is likening parenting to drinking from a fire hose. That people, it's actually fairly difficult to reevaluate your goals for parenting and how well your methods are working, because it's really coming at you so fast. So that's one of the analogies I use. Do other people have things that they say to start to help parents see that maybe they need to take a higher view of what's going on here? Emily usually has a great catchphrase for something. Do you like the fire hose one, Emily?
Yeah, I mean, it is certainly, they don't come with an instruction manual.
Yep.
It's really hard.
Yeah.
And often not intuitive. It's, you know.
Yeah. Especially if you have a kid who's a little bit different.
Yeah.
Who you don't recognize their response pattern. So maybe you were a good little girl. This particular mother I was saying, who was having those verbal interchanges with her teenager, she portrays herself as the perfect good kid. And so she just doesn't know what to do with this kid because she doesn't have another experience. Actually, her other kid, the twin sister, has autism, so that doesn't help because there's some other things going on in that dynamic.
One of the things I find myself doing when you see that is identifying some things that you've observed the parent did with the child that worked, like the evil eye or things like that are effective, and talking to them about what. So, you know, one of the problems is this all comes natural, and you want to see what's in their repertoire that already is there that you could reinforce and help differentiate from the part that's not working.
That's not working, right. And it also helps them not feel so humiliated themselves, because often this conversation feels a little humiliating to the parent. Like they're stuck, they feel like they're failing at things.
Yeah, it's a cultural, judgmental kind of thing that makes people vote a different way, stuff like that.
Right. Can be. So one of the things that I think is a dynamic in some of the long-term side effects or adverse effects of hitting kids is that the child may know they're loved and they feel love from this parent, but then they also feel pain. And this is a very confusing combination of feelings that can carry forward into future relationships. So if the parent is mostly very punitive and not really very affectionate and is not expressing a lot of affection or admiration to the child, children can basically hunker down, get aggressive, they feel numb to themselves and to others, they have low self-esteem. We know that it can affect learning to have grown up in this way, and it increases the likelihood of depression and other mental health disorders like anxiety, for example. And some of those kids will be driven to cause similar pain to others, whether they actually recognize it, rationally or not. If you're mean to me, if you who love me is mean to me, I'm just going to be mean to other people. And so they do mean stuff like stealing things from people, hurting animals, and being violent. And then as adults, this pain is still there for them, the pain of love combined with pain. And this sets them up for excessive alcohol use, drug use, overeating, smoking, or excessive sexual activities. Now, this is documented. I'm not making this up. I am extrapolating a little bit that the mixed feelings about people you love is part of what causes this. But we actually know something interesting from the ACEs data. So everybody knows about ACEs now, adverse childhood experiences. And that original group of people in the ACE study, the data was looked at again, specifically for spanking. Now remember, these are people now in their 40s who are thinking back to their childhood. So for them to remember that they were hit just speaks a little bit to the fact that getting hit is a memorable event, right? So what they found in reanalyzing this data was that hitting had an independent effect from the other ACEs, but the impact was similar to being abused in terms of its increase in rates of suicide, alcohol use disorder, and substance use disorder. So that to me was really a striking result. And I actually hadn't run into this before. So when I was reviewing for this talk, I was really interested to hear that it was independent from other bad things that happened. And I think maybe part of the reason it operates independently is because these are people who care about you. So you may have a perfectly good relationship with your parent, except for the fact that they're hitting you. So it's a little more complicated. So in general, we know that hitting kids has worse effects if they're not in an affectionate relationship, if it's more arbitrary. And you all know this because you see it. In fact, one of my first experiences in Baltimore, because I grew up in a suburb of Boston, and like I just wasn't in the inner city when I was growing up. And then I went to Cornell, and that wasn't in the inner city either. So here I come down to inner city Baltimore, and a kid will be just standing in line in the cafeteria, and the parent says, stop that, smack. And I just wasn't used to that kind of arbitrary hitting where the kid didn't get any warning about it, and it wasn't evident to the kid what kind of rule they were breaking. So that is worse in terms of outcomes than planned hitting. Now, I'm not recommending any hitting, but I'm just telling you which ones are going to be likely to have the worst outcome. Of course, more hitting over time and hitting at a later age. Those 17-year-olds are getting hit, you've got a big problem there. Now, interestingly enough, some defense of corporal punishment has come from people working with African-American populations because the effect sizes are smaller in African-American populations. And I think that the reason for this may be that the more engaged parents may be trying to get their kids to behave well. And if that's what they know how to do, they'll do that, meaning they're more engaged with the kid overall. And so the effect of the corporal punishment didn't stand out as much in that group. Now, that doesn't mean that it's still not good to encourage and support non-hitting kinds of punishments. But just to let you know, if you hear that argument, that may be part of what's going on. And of course, abuse is one of the side effects, one of the adverse effects of hitting, because most child abuse incidents happen at the end of a disciplinary encounter. Did you know that? So they started out trying to deal with the behavior with discipline, and it ended up being abuse. So that's another really good reason to be talking about corporal punishment, because when they have strategies to use, they can help not accelerate to that point. Now, the people who hit are not arbitrary either. As you know, people who are stressed are more likely to lash out, and that includes people who are in poverty, have mental health problems. Intimate partner violence is a clear precipitant for child abuse and also for hitting, substance abuse, and their own histories of having had adverse childhood experiences because they're passing it down, right? But did you know that people who are depressed are more likely to view their child's behavior in a negative light? Like they see it as more negative than someone else might see the same behavior. And so they're more likely to be punishing. So depression is one of the risk factors as well. So any comments or questions so far? Okay, we're doing all right. So I just want to mention some things about different age groups. So one of the problems with hitting kids under 18 months, and I showed you the rate. So under 18 months, we would be talking about a large proportion of kids getting hit before 18 months, maybe as much as 50%. They're more likely to actually get an injury from being hit. It has to do with they're little and their heads are big, and their heads sometimes are the things that you get to first if you're lashing out at a kid. So physical injury is much more likely. Of course, infants also don't know what they did wrong. They don't know what the rules are. And one of the side effects of hitting infants, because they don't understand it, is it's confusing to them. So they learn not to trust the parent. It's kind of like that dog that you come up to, and when you go to pat them, they shrink back. Instead of being open to learning from the parent, they're less available for learning if they've been hit, and they have a fear response as well. Now, toddlers and preschoolers are the most likely ones to get hit, as I mentioned, under age 3. And a study that followed kids who were 3 years old found that those who were spanked 2 times a month or more were more aggressive at age 5, even controlling for their aggressive behavior at age 3. And they may very well have had aggressive behavior at age 3. But even controlling for that, the maternal parenting characteristics and risk factors and demographics, put them all together, the kids are still more aggressive at age 5. And then these same kids at age 9 showed that there was a correlation between getting hit at age 5 and having more externalizing behavior and lower receptive vocabulary scores at age 9. And then subsequent to that, they were followed further. They found that an increased frequency of spanking was associated with increased frequency of externalizing behaviors. And then, of course, they got spanked more in response. So they were in that hit, act up, hit kind of cycle. So clearly, 2 times a month, parents might think, oh, 2 times a month, that's nothing. Well, 2 times a month is something from the child's point of view. So one of the problems we have in talking to parents about this stuff is that they say, well, I was hit and I came out all right. And you can celebrate the fact that they came out all right. But one of the things that's important to point out is something that we do in medicine all the time, and that is we have to distinguish the fact that there are individually different responses to all kinds of adverse events from child to child. And it's not really possible to totally predict who is going to have the worst side effects. I would assert that those who have more frequent misbehavior and invoke more hitting are probably among those who are going to have more trouble. And in particular, I have an interest in corporal punishment and ADHD. So why do I care about this? Well, remember, I'm a developmental behavioral pediatrician, and about 75% of the cases I see have some variation of ADHD and its comorbid conditions. And actually, that's in general true of child psychiatrists as well. Emily, do you want to comment on ADHD proportion in your practice?
Well, I mean, most kids with ADHD actually don't come to the child psychiatrist, right? They're mostly taken care of by primary care folks across disciplines. The kids that make their way to a child psychiatrist either have really severe ADHD or have a lot of trouble tolerating the standard medications, or it's comorbid with anxiety, depression, or other psychiatric dysfunction that makes it harder to manage, and then they get referred. But we don't take care of most ADHD.
Right, exactly, which is actually why it's so important to be having this conversation and making it available to primary care providers, because primary care providers are the ones caring for ADHD. And so what's so bad about ADHD? Well, first of all, the kids are in constant motion. That's part of ADHD, right, for the hyperactive presentation. They tend to act impulsively, which means they do things that look pretty stupid to the parent, and they do them over and over again. Don't touch that, and then the next moment it's moved, right, or broken. And then because they're constantly getting themselves in trouble, like they're constantly doing things that would not be considered to be appropriate from the parent's point of view, they get tired of apologizing. Oh, I didn't mean to. Oh, I wasn't thinking. They don't like to continue to do that. They don't like to continue to that. So what they end up doing is saying, I didn't do it, or it wasn't my fault. And that denial can drive parents crazy, particularly as the kids get older. The parents get more and more judgmental because they want the kid to be accepting responsibility for their actions. How many times do we hear that? The other thing that tends to happen with kids with ADHD is that impulsivity also extends to how they talk to the parent. So the parent says, pick that up. The kid says, I did. The parent says, no, you didn't. The kid says, stop telling me what to do. And so that there's this repartee back and forth that the parents experience as disrespectful. And that's one of the common reasons for getting punished as a school-age kid, is that the parents see you as being disrespectful. So I think that talking about corporal punishment, particularly in kids with ADHD, is really important. I also feel as though there's some kids where I think that they are acting as badly as they do because they were hit earlier. That, in other words, the degree of severity of some of their symptoms may be related to the kind of punishment they got earlier.
I find that I've been surprised that parents understand that ADHD causes inattention, and they can give them some slack or inattention. They don't get it that impulsivity is part of ADHD. It may be, when we're talking to parents, we need to help them understand about impulsivity as well as inattention. That's, anyhow.
Well, I think it's important, very important, Ray, because they're trying to constantly sort out, and people will even say this to me. They say, I don't know how to deal with this because I don't know if it's just his ADHD or, and fill in the blank. And fill in the blank is he's bad, he's got a moral failing, or I failed as a parent in some way. We'd like to think that they were thinking that as well. But that they have trouble sorting out the symptoms. And heaven only knows, the more normal the kid is in other ways, the harder it is to sort that out. Okay, so in this article about the policy statement, there was some interesting data on the physiological and brain effects of corporal punishment. And granted, these are fairly small studies, 23 young adults who had prolonged and repeated exposure to harsh corporal punishment had reduced prefrontal cortical gray matter volume and performance IQ. Well, who knows what the gray matter volume and performance IQ of their parents who were still hitting them is, but it's an interesting finding. Also, MRI differences were found in white matter tracts of 16 young adults who were exposed to verbal abuse, even though there was no history of trauma. And the other thing that was noted is that the cortisol reactivity of kids who've been repeatedly exposed to corporal punishment resemble those of people who've had other toxic stress exposures. So basically, these are exactly the same kinds of findings that you get from ACEs, right? Well, I already told you that it's like an ACE. It acts the same as if you'd gotten a child abuse ACE. That's basically what it is. So what do we know about the importance of trying to teach parents about this? Well, first of all, we need to keep in mind some of their own bent, which I'm going to talk about in a minute. But the goals may be to help people avoid escalating to corporal punishment when they're in the middle of doing something disciplinary. We know that timeouts can be taught during a single office visit, although it's better to reinforce it at future visits, and that motivational interviewing techniques can help parents decide to use other disciplinary techniques. There was data that parents who read a research summary of the adverse effects are more likely to decrease their positive attitudes about corporal punishment. It has some impact on their thinking. And parents may spank less or not at all when they've learned other things to do, because 65% of the time, parents feel as though spanking was the wrong thing to have done, but they didn't know what else to do. So that's work from Murray Stress that I'm reciting. So here's a time when I'm really glad Shirley is on the phone, because she's dealing with a different culture. And we know that there are huge cultural differences in what people think is reasonable discipline, appropriate discipline. And people tend to repeat what they experienced, and they get easily offended and feel judged when you talk to them about discipline. That's one of the hazards here. So some of the things that I think are helpful are first to make observations of the child. You might make an observation of the child, gee, your child is really well behaved, but you might also make an observation about the child, wow, this child is really into everything, and then ask them, how is that for you at home? And the other question I like to ask shortly after that is, how bad does it get? What do you find that you have to do about it? And that often will elicit a history from them, rather than you saying, do you hit your kid? You can sort of go at it through, what do you find that you have to do to manage your child's behavior? Because of course, everybody should manage their child's behavior. So it's a little bit less judgmental. And it's also appropriate to ask permission. May I offer you some ideas? Or even, I know some evidence-based ways to handle behavior like that. Would you be interested in hearing about it? So that's another way of asking it. And be sure to listen carefully to their counter arguments and respond to those. I'm going to talk about the 3-week trial of no spanking in a minute. So, but I want to talk a little bit about these steps of the discussion. So when working with a child with child behavior, talking about specific examples is really, really critical. You can't say, oh, if you say, how are things going with behavior? And they say he's the worst. There's nothing you can do with that. You really need to get into specific examples. And sometimes you can use an example from the very same moment, very same morning that they came in. And then some other good follow-up questions I used are things like, what would he have to do to get hit? And how did it work out? So I'd like to hear, Shirley, would you like to comment on what kind of lead-ins you use in talking about punishment with parents? Can you unmute yourself so we can hear you? Or Diane?
I'd like to hear Shirley's there about what she sees in her environment, which is Indonesia.
Right.
This is Diane, and I think the framework is excellent, and the data is robust and is pretty consistent over the years about the importance of helping parents identify and utilize alternatives to spanking. And as part of a comprehensive pediatric visit, I'm looking at this and wondering, how do you do this? Time-wise, we already are integrating so many developmental, social, emotional, behavioral conversations into visits. Are there anyone on the call who have a primary pediatric office and can talk about how do you integrate something like motivational interviewing, which is fabulous but takes time, into an already extended visit?
So Shirley, I think, operates as a developmental behavioral pediatrician, and we can't hear you yet, Shirley. I hope you're still there. But I would just say that there were a couple of studies cited in the policy statement that talks about fitting it into primary care. I think the first thing to remember is that for many people, discipline's going fine, and that we have relationships with people over time, and that if you can start out giving brief advice at the youngest age, for example, in infancy, talking about distracting and removing kids from things that they shouldn't be doing. And there's a chance to say, of course, it's important not to hit your baby. That's a chance to just fit that one in. And then when they get more active and start doing things that appear to be sort of more intentional, typically around a year of age is when you can introduce the idea of timeout. But let me just point out something about timeout at that age. And that is, the main thing about timeout is to show that you're not happy with the child's behavior. Don't reinforce it with a lot of emotion on the parent's face, and that you can simply plop them down on the floor, not hard, but put them on the floor and say no biting or no touch or whatever the thing is that the parent's trying to do, and then turn away briefly. And the children will often cry immediately because they understand the displeasure of the parent. And then the parent, as soon as that phase is over and the child has basically given in to sitting there, then quickly take them out and move them onto something else. So that takes no longer to explain than what I just did, which I would, if I were measuring that, I would say that took me about 15 seconds. So it's basically, you can fit it in to the visit by giving a description of exactly what they should do pretty quickly. The harder ones are where they're already hitting and they don't want to stop. And I think that may be what you're reflecting on.
I think I want to comment a little bit about the motivational interviewing. Two things. First, I think the essence of motivational interviewing is that we're acknowledging that people are ambivalent about doing it, and that giving simple advice, this is the right thing to do, may not address some of the other reasons, like well, I can see why it stops him right away. And when you did that, he just really stopped. But on one hand, that's a benefit, and then on the other hand, and you tell the other hand, which is the long-term consequences, and there are other alternatives. So that's a kind of the essence of motivational interviews. The most important thing is that recognizing the limitations of simple advice and trying to understand where their barriers and ambivalence may be coming from. But I also am tempted to to tell you that in Chattis, we particularly have been trying to figure out how can we facilitate motivational interview, because sometimes it does take time, and that's just what you're talking about. So we have a questionnaire that asks about having trouble with the child's behavior, and asks about particular examples and what they may be doing about it, and why, how bad it is, and all those kinds of things, and what they would do if things got worse. All of the data gathering part of motivational interviewing, and then for the doctor, we provide a teleprompter that gets to the essence of motivational interviewing. I mean, I think there are a lot of ways to learn that, but we are trying to help solve the problem by finding the cases where the parents are most ambivalent and giving some ideas of how you might, what words might work on the spot, and also triggering some the educational kinds of information about corporal punishment and alternatives to a more effective discipline in the memory book of Chattis. So there's that would be part of a intervention study that's going on right now called the Family Stress Study, if you're interested.
Yeah, Diane, are you in the Family Stress Study? I don't think so, are you?
We are not. No.
Would you be interested? Because this is one part of it. Because the Family Stress Study has as its outcome measure reduced child maltreatment. That's actually what it's about. And so that's part of why I'm talking about this today, is that helping people to have conversations about spanking is actually probably one of the more important things we can do to prevent child maltreatment.
Yeah.
Would you like to see those?
Sure. I'd be interested in learning more about that. I almost see this, I'm the parenting and child development specialist at our practice. I'm not the physician. But when we launched a more robust asthma program here at Weiss Pediatric Care, it turned out that our providers started the conversation and certainly created the care plan, but then our nurses did some of the education with the device use and things like that, and making sure parents understood their care plans. I almost see this as most effective if the conversation is started perhaps by the provider, but it takes more time. I certainly want to learn about the stress project that you have, and very interested in how you integrate this, because I agree with you, it's critical, but I do know that this is a paradigm shift for, what did you say, 72% of parents, maybe more? And so we don't get that much time with them. I'm looking for how can we make the biggest difference in the shortest period of time, while honoring where people begin the conversation, which is 72% of them or more believe in spanking. And yeah, and so I think the challenge is how to retrofit this into a pediatric primary care practice, not whether.
And that's right. Yeah, and that's what this project's designed to do.
Right, but
we'll talk to you about it another
time. But to salute what you're saying, I think that often, let's just go down this slide a little bit further, because here's what tends to happen. So you elicit an example, you empathize with their pain. That sounds really hard. It's really embarrassing when he acts like that in the store. Ask them, what have you tried so far? What works best? Often they have found something that works best, but it's not working in the context where they're doing it. And then the next bullet is, what does your partner say about this? And how would your parents have handled this when you were growing up? Those two questions are really important, because often it's the partner who's hitting, not the person who's in the office. So then being able to bring that other person in for a subsequent visit may be really important if hitting is a big part of what's going on. And asking, how would your parents have handled this when you were growing up, I find useful, because they say, oh yeah, they used to hit me with a belt and I sure don't want to do that. And that's a good one. Or if they say, well, they would hit me when I needed it and I deserved it, and I think it's why I came out well. And then sometimes I ask about that. Well, what's your relationship with them like now? Well, I haven't talked to my dad in about 5 years. So in other words, they may recognize that even though it seemed to help them, the structure, that it doesn't work out well for them in the end. So often inviting somebody back in, and the slide I skipped over about well, how about, teach them timeout, which again takes about 1 minute in the office, and then say, how about trying this for 3 weeks and then coming back and bringing your partner with you so that we can talk about how it's working. And even if the partner doesn't come, in my experience, what often happens is when the partner sees how well the timeout works, in 3 weeks you can start to see that they then are willing to stop hitting also. So those are some pieces that fit it in to a typical visit. And I think that we know that behavior is the presenting complaint in 25 to 50% of visits. It's really right on their mind, and finding out which behavior it is that's bothering them the most is generally the one that's getting hit about, right? They're getting hit for that behavior. So it really gives you a chance to drill down into the issue that's probably most important to them. And yes, they're supposed to get their shots, and you want to ask about whether they're brushing their teeth and so forth. And of course, Chad has helped sort through some of that stuff. But this may be the most important thing that you do as a pediatrician or as a pediatric practice, is to help people have relationships with their kids where they're managing behavior without having to be harsh with the kid.
Dr. Howard, I have a question though about, in primary pediatrics, we can't get paid for this. If I have a patient come back, and I agree with you, it's critical, we do it for free because there's no code for this that anyone will pay us for. And although we do so much because it's the right thing to do and we don't get paid for, this is, that whole conversation you just had, I think would take a good 15 minutes because no parent answers with one word. They go on, I did this, and then I did that, and my mother says this, but my father-in-law says that. And so, this takes patience and time, and I think it's really, I'm just struggling with how to do that because we can't get paid for this. There's just no way.
Well, there are two ways you can get paid. First of all, you can bill on the basis of time, and typically, if they have those issues, if they're hitting their kid a lot, probably there's another diagnosis. It might be oppositional defiant disorder, that's a possibility, but it might be a sleep disorder. By the way, one of my favorite things to bill for is a sleep disorder, because those same kids, they're not going to sleep. And so you can put sleep disorder on there and fit in discussion about how to structure sleep in with your discipline. So that will frequently get paid for, if nothing else. And of course, sometimes the kid has ADHD, and then you can bill it as an ADHD visit.
Well, while primary care has the limitations of time that you've talked about, but also the advantage that you could begin this conversation when the child's 1 month old, when you ask about how were you parented and your experiences, and sort of setting the stage for a conversation that could continue over a period of time as you are using a kind of surveillance and vigilance for this kind of these kinds of issues. So it's not something that comes up when the kid's 5 years old and got kicked out of school.
Right. So putting little pieces in over time really helps. And if you do any kind of parent groups, this is frequently a topic for parent groups as well. Well, let me just talk about a few things we know about effective discipline. So the first thing that often needs to be done if there's a parent who's spanking their kid is to work on having more positive interactions between the parent and the child, because oftentimes kids are acting up to get whatever attention they can get from the parent. So daily, irrevocable, meaning they don't lose it no matter how they act, daily special time, and coaching on quick attention to desirable bits of behavior. I frequently use marks for this, which you've probably heard me talk about before, but just helping the parent know that they need to be looking to praise little positive bits of behavior. And then when some kind of intervention in a behavior is needed, get eye contact, get down at the kid's level. First, acknowledge the child's point of view. You really wanted that toy. You wanted it a lot. Brief explanation of why a behavior is not okay, but it's really your sister's toy, and she didn't want you playing with it right now. So because you hit her, you're going to go into timeout. But some of the other kinds of consequences are the toy goes in timeout. You go in timeout. If you're older, you get a chore card, for example. That means a chore you have to do. Or there can be a loss of privileges. So these are the main kinds of consequences that all have good evidence. And one of the things that is really important to talk to parents about is that smaller consequences work better than large ones. this is a kind of a confusing notion for parents. They think, well, the bigger the offense, the larger the consequence. Well, actually, things tend to work better with small consequences. And this can be a source of relief for the parent because you can't keep the kid in timeout for 30 minutes. You know, you just can't do it anyway. So making them know that if they use a small consequence, it's going to work is very helpful. And then having a clean slate basically means clear the air in the relationship between the parent and the child. When the child has done whatever the consequence is, act as though everything is good again. Now, these are the steps for timeout, and this is the most evidence-based consequence for child rearing. First of all, there should only be 2 to 3 behaviors worked on at any one time. Typically, it's aggression, aggression, and aggression. The psychologists who do this have learned that if it's practiced before you have to use it the first time, that helps, like instruct the kid. I'm usually too late for that first time because they're coming to me as a consultant. There should be only one warning for a behavior, but no warnings for aggression. Kids know they're not supposed to be aggressive. A brief statement of the offense, placement in an uninteresting place, not a closet. And then 1 minute per year of age is only a general rule. In fact, the busier the kid, the shorter the timeout. So what I recommend is put the kid there until they sort of go humph, and they show that they've given in to the fact they're going to sit there, and then quickly get them out again and distract them onto something new. Now, if they leave timeout, they could be restrained, like held in timeout, or they could be put in something like a playpen. Forehand, who did most of this research, put them behind a plywood barrier so they could see out, but they couldn't get out. That's pretty elaborate to do that. Then no discussions or lectures afterwards, because at that moment the child is very vulnerable. Instead, to comment on the first positive or neutral behavior, and then later on talk about what happened and what they could have done differently. Once they understand how timeout works, you could restart the timer, but I have moved more and more towards this until the child resigns himself to sitting in timeout kind of a rule. Here are some of the resources. They're in the article, and this is the reference to the article. Let me just mention, in particular, Triple P is getting international recognition as being a valuable strategy and a counseling strategy that can be done in primary care. That's what it was designed for. So if you have an interest in this area, Triple P is a good place to look.